Hi, everyone. I am so very excited to be here today to talk with the one and only is going to join us in just a moment as I pull her up to join us.
Hi.
And Stacy's here. Let me just get Dr. Teplinsky on. Here we go. She should be in here any second. So here we are. Hi.
Hi, how are you?
Oh, it's so good to see you. I'm so glad you could make this, and we are, oh, I am very low here, here all
Yeah,
together
I'm excited.
on the very first, am I right? It's the first
hmm
ever World Menopause and Cancer Day. Is that
That is
accurate?
correct. Yeah, so good timing. We actually didn't realize that it was this day when we decided on this.
Amazing. So it's
Perfect.
meant to be. It's meant to be. So before we get started, I'm just going to give a little bit of an introduction about who you are, and just tell everybody out there that we are thrilled to welcome you back this coming January 2026 for the second Not Your Mother's Menopause event that we'll be having in Maplewood, New Jersey. You were one of the highlights of our first event, and so many people had, as we're going to know tonight as we see all these people joining in, about how many people have questions about this topic. But Dr. Eleonora Teplinsky is a board certified medical oncologist specializing in breast and gynecologic oncology. She's the head of breast and gynecologic medical oncology at Valley Mount Sinai Comprehensive Cancer Care in Paramus, New Jersey, and a clinical assistant professor of medicine at the Icahn School of Medicine at Mount Sinai. Her clinical and research interests focus on young women with breast cancer, survivorship, and the use of social media in oncology. She's passionate about patient education, advocacy, and empowerment on social media, and is obviously here on social media herself, and everybody should follow her. I'm sure you all are following her. There's so much more to say about you, but I think we have so much to talk about.
Yeah.
So I wanted to start, if I can, I just want to start with what happened? What went wrong? What happened to the information? And how did we get to this point where we are, where people are terrified of hormones and cancer and the relationship between the two?
Great question. I mean, I think there's a lot of backstory to this, but I think that dates back to when the Women's Health Initiative study was presented, early 2002, all the headlines splattered across every social, news media channel at that point. Hormones cause breast cancer, right? And right away, the hormone prescriptions were being yanked away from everybody. And so there became this fear, and we now know that the Women's Health Initiative was really misrepresented in the media, and that estrogen alone in that study did not increase breast cancer risk. It was a slight increase in the combination of estrogen plus progesterone. Challenge with all of this is, like, how do we use all of that information in today's day and age where we use completely different hormone formulations? So it's really even hard to say that the data from 2002 still stands now. But because of that, we haven't had these studies. So we're really in this kind of dark gray area. And because of that, there were a number of studies at the same time looking at hormones after breast cancer, and we can talk about some of them. But the bottom line is there became really this, like, you can't have any hormones if you've had cancer. And while some of that, we can kind of dive into it, but that's now extended it to, well, if you've had a family history of breast cancer, if you've had pre-cancer, if you're at high risk for cancer. And so really we now know, wait a second, it's not a blanket contraindication for everybody, right? I feel like we should be thinking about each situation on an individual basis. And then also, I think everyone should be entitled to make their own decision about what to do in conjunction with a team of physicians and healthcare providers that are really on your side and trying to help you navigate through some of this.
Great. One of the things that people ask us all the time is, and this came up after our first conference, and I'm sure you get this question a million times a day. Everybody wants to know. I have a family history of breast cancer.
Mhm.
Are hormones safe for me to take? Um,
Yeah.
everything that we, yeah, like everything that we see and
Mhm.
that we've learned is quite the opposite to what everybody thinks.
Yeah, I mean, I think it takes a lot of time to change that dogma, but also people are going to their doctors and are just being told no and without a conversation. So that's also, I think, part of it. It's going to take time to change. I mean, this was a huge paradigm shift when the Women's Health Initiative study came out. So it's going to take a long time to kind of shift the needle. But the beauty is that we have a lot of amazing physicians talking about this on social media and with writing books on the topic, going on media channels. And so people hopefully are going to their doctors and say, hey, can we talk about this? Can we have a conversation? But I think when you come back to this question of family history, bottom line is that family history alone is not an absolute contraindication for breast cancer, but this is a great time to talk about what is your breast cancer risk. Are you at high risk because of this family member, right? Is it a mother who had breast cancer at 30? That's very different than a great grandmother who had breast cancer at 89, right? Those two things are very different. Do we
Right.
need to get genetic testing? There are a number of calculators out there that are going to help you figure out what is your breast cancer risk? Do you qualify for genetic testing? And with that risk, we can then say, okay, wait a second, what are we thinking about with hormones? What type of hormones? What are we going to do? What does that risk look like? And then help patients make that decision. So it is absolutely not a blanket no, but I do think that it's important there to have a pause and say, okay, well, let's talk about your risk first, because one of the things that I see is people do not know their breast cancer risk. And breast cancer risk is much more than just family history. We have reproductive and personal history. And then what are you doing to your body on a daily basis? Because lifestyle makes a big difference as well. So I find in my world that people aren't aware of their risk. And I think that's because we're not talking about this. And so that really is the first place to start.
And so go ahead, Stace.
No, keep going. Because
Okay,
my
no, I
brain
was
is
gonna,
like, I have so many. You keep going first.
no, it's,
We're gonna dive deep into
Yeah.
vaginal estrogen, but
Oh
keep
no,
going.
yes, yes.
that's on the
So wait,
list.
let's just qualify this that everything we're talking about right now is systemic. Vaginal estrogen,
Correct.
like I can, yell at from the rooftops, please
Yeah.
take vaginal estrogen.
Yeah.
Like, can we just say that everybody, like, is this true, Dr. Teplinsky? Everybody can take vaginal estrogen?
So not medical advice here, but yes, in general, we are
Right.
very comfortable with prescribing vaginal estrogen for everybody. There are some studies, and there's one study that everyone cites when they want to say, no, you can't have vaginal estrogen. That said, people who were on aromatase inhibitors who used vaginal estrogen had a higher risk of recurrence. So naturally, again, oh my gosh, fear, right? I'm on an AI and I might have a higher risk of recurrence. The problem with this study is multiple. Older data, very small number of patients, used much higher doses than the low dose vaginal estrogen that we use now. It predates all of our current treatments. And we think that in that study, very few people were using an AI and most people were on tamoxifen. And so we think that that group was actually more of a higher risk population to begin with. We don't know, were they compliant? There's so much we don't know, and so I always like to debunk that study because that gets thrown around a lot for patients who are told you can't have vaginal estrogen, but that study doesn't align with all of the other studies that we have saying that it's safe. It does not increase mortality risk. And we know in other studies that vaginal estrogen can save lives. It can reduce the risk of urinary tract infections that lead to sepsis and hospitalization. And so there's really a lot of power in being able to take it.
Yeah.
So I've been a pelvic health therapist going on 30 years. So I feel like I've seen it and I've seen the transition go from women that come into our practice, and most of the women coming into my practice have pain with intercourse or urinary symptoms, whether it be urgency, frequency, leakage. And then we have our patients that have histories of whether they've had breast cancer or on tamoxifen. Um, and this comes up a lot. And I remember there was a study, and I'll never forget it. This is probably going back a while ago, the British Journal, I think of sexual medicine. I don't remember exactly, but they used lidocaine. It was lidocaine for breast cancer survivors that couldn't use vaginal estrogen. And because they were trying, yes, this is a
Yeah.
study, British
So
Journal. I don't
I
remember
will
which one.
I will tell
But
you that I actually do sometimes prescribe lidocaine on top of
correct.
vaginal estrogen. It actually can be helpful.
Works.
It's not, doesn't always work, but it does help some people, especially people who are having pain right, with intercourse right at the introitus.
It's I've
I've
been asking and
thankfully
begging
never heard
for
that.
it. Yes. So what it does is it's a it's a mind body thing, right? So if you constantly feel pain every single time you have penetrative intercourse, the minute anything comes near you, you're going
Yeah.
to
They're
contract,
like,
right? Like
yeah.
you're not going to want it because it hurts. So the lidocaine is actually a brilliant idea. Also, if you've ever had really bad mouth work done, before they inject a needle into Novocaine, they'll put a Q-tip of
Hmm.
really high amounts of lidocaine so you don't feel it.
Yeah.
So you're
Yeah.
like, oh, that was not bad. So
Yeah.
then you don't have a fear of going to the dentist and getting that. So that's where the lidocaine comes in. And lidocaine's fantastic.
Yeah.
But we do know that obviously vaginal estrogen, when you see an introitus that is just so malnourished of estrogen, it's a hard tissue to stretch, right? Like it
Yeah.
just is. And that vaginal estrogen just does what people are doing and putting it on their face. Like it
Mhm.
plumps up the tissue, it makes it more hydrated, it brings more blood flow. And how I know you went to the FDA, or we had a bunch of people who
Yeah,
went to
but
the
yeah, I was not there. But yeah, a bunch of people went to
yes.
the FDA and trying to remove the label. But what I can tell you is that I must prescribe, I don't know, multiple prescriptions of vaginal estrogen a day. And recently, several times in the last few weeks, people have gone to the pharmacy to pick it up and they're, no, no, you can't have this. And so now the patient says, wait a second, the pharmacist said I can't have it. Why is my doctor giving it to me? Because I get it. The label says can't have if you've had cancer, if you've had heart disease, all these, other things. And so there's a big push to remove that label because it also just causes a lot of distrust and people don't know what to do and they don't know what's real and what's not real. And, the FDA label says you can't have this. So
Right.
it's really
And
outdated.
I guess it's all like what everybody says, and all the medical professionals who we speak with always talk about risk reward, right? So what you're saying, Dr. Teplinsky, is the risks, according to these studies
Yeah.
that are old and outdated and now need to be redone, the risks seem to be much
Yeah.
smaller,
Mhm.
statistically smaller than what we're seeing, what Stacy's saying, and what you're also saying about the rewards of being able to use this product.
And we also have a lot of studies that do say it's safe and there's no harm, right? So we do have that data. Are we going to have a beautiful, perfect study where half of the patients get vaginal estrogen and half don't, and we follow them for 20 years and we see what happens? No, we're not. And that's probably, I wouldn't even think that's right to do because we don't want to deprive people of vaginal estrogen at this point.
Mm.
So I think we have to understand that what we have is not great in terms of, but we have a lot of data and benefit, again, risk and reward. And I think one of the things I feel strongly about and try to educate and advocate on here is I want people to be able to have a conversation, right? So it doesn't help when you go to your doctor, and I hear this from women day in and day out. They're going to their doctor and they're being told, nope, you can't have this, without even a conversation. And I think that's the hard part, right? Because then the door is closed. It didn't even open. And so one of the things that I really urge people to do is to say to their doctor, I'd like to have a specific visit to talk about this. Okay, here are my concerns. I'm going to bring someone with me. And if you, because and the visits are short, you're limited. So if you make a specific visit to talk about this topic, and if you can't even have the conversation, then maybe this is time to find someone who you can have that conversation with.
Yeah.
When you talk about that, like sort of this risk analysis, if you will, of your family history or your cancer or your own personal cancer history, plus hormone therapy. How can you talk a little bit about the kinds of questions that, like maybe the top three questions that you would recommend that people put in their wheelhouse to take to their doctors to start this conversation?
Yeah.
Because I wonder if maybe some people are like, I don't even know how to start having this conversation.
Absolutely. I think that's a great question. So there are a number of models and calculators that exist out there that help you figure out your breast cancer risk. The one that is most commonly used, it's publicly available, it's been made more popular through people like Olivia Munn talking about it publicly, but it's the Tyrer-Cuzick model, or the IVIS-2 model. You can plug it in online, comes
Send it to
out,
us and we'll put it in the,
yeah, I'll send it in there,
yeah.
yeah.
So when we put this on, we'll make
Mhm.
sure that people have those links.
And it asks, it just goes through, it asks your age, it asks when you started menstruating, menopause, have you used hormones before, your family history, all of these questions. Have you had cancer in the past? So there's a whole list of questions, your breast density. It really tries to figure out your height, your weight, all of these things, and it calculates your 10-year lifetime risk. It's not perfect by any means. It asks if you've had genetics, because it doesn't take into account lifestyle. And we know lifestyle plays a big role, but I like to think of it as it takes into account the risks you don't have control over. So the non-modifiable risk factors. And with that, you can get a number knowing what your lifetime risk is. So if your lifetime risk is, let's say, 30%, anything over 20, you're considered high risk. So right away, we should be making sure you're talking to somebody about getting a breast MRI as part of your breast cancer screening. So that's a place to start. And then that may help you have that conversation about hormone therapy and genetic testing. So a call to action for anyone listening is to say to your doctor, I would like to know my breast cancer risk using the Tyrer-Cuzick model. Because a lot of times
Okay.
if you just say breast cancer risk, people are like, no, you have no family history, you're fine.
Yeah.
And in this model, what I like about it is that it goes deep, and it asks you for parents and first degree relatives and grandparents, kind of does a very comprehensive family history. So that's a great place to start. And this is something that, as October is coming and Breast Cancer Awareness Month is coming, as we think about this is really the time to have these conversations.
That's great. That's really great advice. I'm going to jump in. We've got some questions. I'm just going to jump. There's one question, and I know that one of the things that we always have to deal with when we're talking about this is people having very, very, very specific questions. But I do want to be able to I do want to give the platform a little bit to some people. So there's somebody's written and she says, is there any information about taking testosterone for women that have had and I'm not an oncologist, so I'm going to say it's estrogen progesterone or ERPR positive breast cancer and are on AI.
So ERPR positive, that's going to fall into our hormone receptor positive breast cancers, which is about 70% of all breast cancers. Testosterone, there's just not a lot of data on this topic. There are a few, albeit very limited, studies on using testosterone when someone is already on an aromatase inhibitor. And the idea is that aromatase inhibitors actually prevent aromatization, or the conversion of testosterone to estrogen. And so the thought is, if you're taking testosterone but you're on an AI, that testosterone won't get converted to estrogen. And so that's where some of that data comes from. It's very limited. We just don't have a lot in terms of long-term safety. And so these are very nuanced conversations. One of the concerns in using testosterone, although a more theoretical concern, is that some breast cancers can have androgen receptors. So if there are any microscopic cells floating around, right, what we're trying to do is keep them from getting estrogen. But if they have androgen receptors, they might want that testosterone. Again, more of a theoretical concern. So I think that these are really nuanced conversations. And what I say to my patients is, let's talk about it. We have limited safety data and limited long-term data. And so then I try to think about, okay, if we're going to use it, let's think about ways that we can try to manage some of these side effects. And then we come to a decision together. I do have some patients who have made the decision to take testosterone, and I have other patients who've said, you know what, I'm going to try, A, B, C, and D first, and then we can revisit it. So I think it's a very nuanced topic, but we just understand we don't have a lot of data. And I think testosterone as a whole, there's what the FDA approved label is for testosterone, and then there's probably a lot more benefit that we just don't have the label for, but people use it for because it really helps. And so I think that's just an evolving field as well.
And I think this goes to the next question that says, what is safe for low libido in triple negative breast cancer survivors?
Yeah, so there's a couple of drugs that we can use for low libido. Same thing with testosterone in triple negative. I would want to see like how far you are out from your diagnosis. Some triple negative cancers can have androgen receptors as well. So a lot of that depends on, when was your diagnosis, what are we dealing with, the stage, all of that. But aside from testosterone, there are, and in triple negative, we actually feel more comfortable using hormone therapy, so estrogen and progesterone. But there are medications that are approved for hypoactive sexual desire disorder, which essentially is low libido and you're bothered by it. Some people have low libido, but it doesn't bother them, so that's different. But hypoactive sexual desire disorder is low libido and this is distressing. And so there's a couple of medications that are available. One of them is flibanserin. There have been data for it in breast cancer. There's another one that is less commonly used, but the flibanserin is something that I do prescribe to patients. People do find it helpful. It's typically given for about 6 months. And so there are things that we can do. Working with a sexual health therapist can be really important. Working with your gynecology team, your menopause specialist can be really important.
Great. We have so many like
Yeah, I
amazing.
have to just take a quick break. I will be right back.
Sure.
Maybe
Got it.
just 2 seconds. I will be
We're here.
right
We're
back.
here. I'm just
Okay.
gonna scroll through these people who are out there. There's so many great questions coming in. Can you see these, Stace?
I can see them. One thing I want to say is just to remind, because I think a lot of people follow Dr. Teplinsky and don't know about our event. So our event is Not Your Mother's Menopause. It's our second event. It'll be held at the Maplewood Country Club. So if you're
In
local
Maplewood, New Jersey.
in Maplewood, New Jersey, so I don't know who is on here from New Jersey. And our tickets actually go on sale October 1st. So you can get that information on our website at NotYourMothersMenopauseNJ.com. So get on our list.
Yeah. Dr.
And
Teplinsky is she'll be back for a second year
yep,
talking about
and
all this stuff.
we also have last year's event that you can actually purchase for a reasonable amount and watch all of last year's put into categories all about menopause, and Dr. Teplinsky is part of that as well. So
Yeah, and I think it's 25% off now if you want to
I
go to our
I
I think we have a sale on our
I think
video.
we have a
We have a sale.
sale.
I know, I'm super excited.
All right,
I
I'm
didn't,
back. I'm back. Sorry.
That's
that's
okay. We were
okay.
just promoting our
We were
event.
just
It's
plugging our
totally
event. No, you're
fine. We got
Oh,
you.
perfect. Perfect. Perfect.
Oh my God, how funny. So it was a perfect commercial break. I know, I
Look at
love it.
that. Amazing
Can
timing.
I read can I just read these questions, like this is such an engaged group. I'm gonna start. Here's a question. I'm 45 years old. I just started Zoladex yesterday. Does starting menopause earlier through treatment affect long-term bone or heart health differently than natural menopause, or is it the same? This is a very good question.
Great question. How old do we have an
45.
age? 45. So a couple of things. The data shows that if you go into kind of permanent menopause before the age of 45, there can be increased long-term problems in terms of heart and health, brain. However, there's so much that we can do, right? So when we have these numbers and these statistics that say, oh, if you're going into it, at 40, you're at risk, but we're not there. These studies are also not incorporating how we're going to make all these lifestyle changes. So I just want to put that out there. But in terms of people so if this person is going into it at 45, based on the data, we wouldn't say that there is long-term, severe increased risk in heart, bone, and brain. With that said, in people, let's say, who go on ovarian suppression at age 35, for example.
Yeah.
Right now, the data to do that is for 5 years. And so at 5 years, you're 40, and we then stop the ovarian suppression. So Zoladex or Lupron are drugs that shut down the ovaries, which can help reduce the risk of breast cancer recurrence. But after those 5 years, we can stop the drugs. And I like to think of it as you just turn the light switch off for 5 years, and now we're going to turn the lights back on. And we don't know necessarily what's going to happen with the ovaries, but we hope that there's going to be at least a dim light that's going to make some estrogen that's going to help you with that long-term health. So this is why, if we are permanently putting someone into menopause at a much younger age for things like BRCA mutations, we really do want to make sure we're thinking about hormone therapy. And those are some situations where, again, these are individual discussions, depending on type of cancer, genetic history, all of that.
Great. Are the side effects of AI permanent, or
No.
should you expect to see them wane?
So it depends on what they are. What are some of the way that aromatase inhibitors work is you have to be in menopause to take them, and they block estrogen production from everywhere but the ovary. So from our adipose or fat tissue, from our adrenal glands, which sit above the kidneys. And so you kind of enter a more estrogen deprivation state. So the side effects come from that estrogen deprivation: hot flashes, joint pain, bone health issues in the long run, vaginal dryness, mood changes, hair thinning, and so forth. Not everyone gets these symptoms. Everyone experiences different things to different extents. But after the length of time that you're on the aromatase inhibitor, when you stop it, you're going to make some of that estrogen. So that's number one. But the symptoms, side effects tend to wane. There are things that we can do. And what I say to all of my patients is my goal is to do what we can to keep your cancer from coming back or to lower that risk. But I don't want to ruin your quality of life for the next decade. I don't want you to look back at your 50s and say, well, I was alive, but it was horrible, right? That's not the goal. So we're working together constantly on what can we do, right? What are we doing for movement? What are we doing for hot flash management? Are we on vaginal estrogen, et cetera, et cetera? And sometimes we can make a huge impact, and sometimes I've had some patients who've made the choice to switch to tamoxifen or stop endocrine therapy because they said for them, it was a risk benefit discussion. So it's really nuanced and really individual.
Yeah.
Got it. There's a lot of questions about the aromatase inhibitors that are coming
Yeah.
up.
We might have to do a whole other live
We
on
have to do just a
that.
whole
Yeah.
live about that. Somebody has a really good question, and this gets into a topic. This sort of broaches another topic, Stace, that you and I have talked about a lot, and that we've talked about in preparing for our conference in January. And I'm just scrolling back to see what
Is
I
it
want
the
to see how she worded.
GLP-1?
It was the GLP-1 question. Should a
Yes.
GLP-1 be prescribed with hormone blockers? This is the question. And I know, and Stacey and I and April, who's not on tonight, have talked about this issue because this topic, and I don't want to get into it too deeply as far as what we think about it, but it really is a topic that is exploding in conjunction with this increased conversation about menopause in general. So
Yes.
GLP-1s are making a big impact, or having a big impact in this whole conversation. So can we talk a little bit about how they would interact, or how you would use them or
Yeah,
not?
absolutely. So this is, I think, an evolving field. There's a lot of really wonderful obesity medicine specialists and endocrinologists that are paving the way here. But the first question I always get asked is it safe if I've had cancer to be on a GLP-1? So that's really a big question. And for the most part, yes, there are some nuanced certain thyroid cancers where we can't give GLP-1s, but in general, yes, we can give GLP-1s. There's not a lot of data on GLP-1s and people who have had cancer. There's a lot of data coming out that's saying if you take a GLP-1, it may reduce your risk of cancer, and whether that's from a weight loss perspective or a metabolic shift and inflammatory change, we don't know yet. But there's not a lot of data if you've already had cancer. And there are some studies that say maybe the weight loss is not as great if you're on an aromatase inhibitor with taking a GLP-1, but the counter argument to that is maybe it's not that great because you're not sleeping well on your aromatase inhibitor, or you're having hot flashes, or you're having joint pain, right? Like
Yeah,
chicken
it's
or egg
all
kind of thing. Exactly. So I've had many patients who have had fantastic results on GLP-1s and who have said, I feel like myself again. They gained 20 pounds as a result of menopause and chemo. And when you're in menopause, when you're on these ovarian suppression drugs, when you're on an aromatase inhibitor or tamoxifen, losing weight can feel like you're climbing up a hill and the rock is just rolling right at you, right? Like no matter what you do, you can be really stuck. So I think that the GLP-1s can help. Now, I think this was posted on Instagram today by someone saying that she's taking a GLP-1 and it's helping with inflammation. We don't have that data at this point. And right now, prescribing of GLP-1 is still limited to people who meet the eligibility criteria for being on a GLP-1. So it should be for everyone. Not yet. We don't have that information. But if you're eligible for it, it can be really beneficial. The one piece that I do think is really important is sleep apnea is higher in menopause. So,
Huh.
and and sleep apnea is a condition for which GLP-1s are approved. And
Interesting.
so one of the things that I refer a lot of patients for sleep studies, because they will come in and they'll say, I'm just not sleeping. And, they're like, no, I'm not waking up because of night sweats. I'm not anxious. Or I am waking up in the morning and feel exhausted despite being in bed for 7 hours, right? We always think of sleep apnea as just snoring.
Right.
And that's not many people don't have that common symptom. So I send a lot of people for sleep testing and sleep studies, because if you have sleep apnea, that can derail all of the changes and the efforts that you're making to be healthier, but it also can help with GLP-1 classifications.
Okay. I didn't know that. That's very interesting.
Yeah. So
Yeah.
something to think, sleep medicine, I think, is really going to be a bigger part of menopause care, as it should be.
What are you, you mentioned something about, I don't remember the specifics just a minute ago, about somebody talking about GLP-1s and inflammation, and and you made a clarifying statement about how that data hasn't really been fully fleshed
In
out
cancer, yeah,
in
in
cancer.
cancer.
Sorry, yeah, in cancer. But I wonder, because you're so active on social media and you see what's happening, what are some of the things that, if you can name like one or two things that you see coming out on social media over and over and over again that you wish wouldn't come out on in
Yeah.
your, like, with the
I think the biggest thing is the misinformation around mammography. I mean,
around, I'm
that
sorry,
shows
about
around mammography
mammography.
and getting breast cancer screening. That's a big one. That every so often people say mammograms cause cancer. They don't. Mammograms have a high radiation dose. No, the radiation from mammography is equivalent to flying cross country. I mean, how many people are passing up a flight to LA from New York, right?
Huh.
And
Okay.
people are promoting alternative imaging that is not FDA approved, that has been people are warning against, and a lot of times they're promoting alternative imaging that they financially benefit from. So I always like to put that out there. Now, mammography is not perfect. If you have dense breasts, if you're at high risk for breast cancer, we do recommend supplemental imaging, but that's in conjunction with the mammogram rather than in lieu of the mammogram.
Great.
Amazing. Love
Yeah.
it.
I just want to reach out. One woman, somebody just wrote that she's not been able to get, and this is something we talked about, because she may have just come in. She said, I haven't been able to get a clear answer as to whether menopausal side effects are worse when having a total hysterectomy versus being put on ovarian suppression and aromatase inhibitors. So we kind of talked about that a little bit but she's throwing her hysterectomy into the mix. So I thought that
So we
was
have to define what a hysterectomy is,
okay.
okay?
Yeah.
So total hysterectomy is removal of the uterus and the cervix. So
Right.
we use colloquially, people will use hysterectomy to say, oh, I got my ovaries and my fallopian tubes removed, but technically hysterectomy is uterus and cervix. If you're thinking of ovaries and fallopian tubes, that is an oophorectomy and a esophagectomy. In terms of whether menopausal symptoms are worse if you surgically remove the ovaries versus chemically shut them down, right? So chemical versus surgical ovarian suppression. In general, no. However, I will say sometimes people find that they struggle with the ovarian suppression chemically because it's every 4 weeks, and like some people get these little like ups and downs with it, like they get the dose and they feel more menopausal stuff and it fades. And so in those people, they actually do feel a little bit better. So when their ovaries are surgically removed, but these are really anecdotal stories.
Great. Good. So I think as a follow-up to the mammogram, somebody wants to know what your thoughts are on, I'm going to butcher, I don't know, lobular?
Globular cancer is a type of breast cancer. It's about 10% of all breast cancers. Most breast cancers are ductal. The thing with lobular cancers is that they don't tend to form a mass or a lump. They like to grow in single lines, and so it's really hard to detect them on a mammogram. And so this has been, one of the things is that if you have a diagnosis of lobular cancer, really want to make sure you have an MRI because
That's the question.
that can better detect it. But again, remember that's in people who were using screening mammogram to detect a breast cancer. And then if you do have a breast cancer detected and it's lobular, we're definitely getting that MRI. So if you have not had breast cancer, then we think mammogram and then an MRI or ultrasound, depending on your risk and your breast density.
God, you're so good.
I
You're so
know.
smart.
Let's try and get her.
I know. All
Let's try
right.
and
I think I
stump
have
Dr.
time for like
Teplinsky.
a
She's
few
just so
more
smart.
questions.
Okay, I want to ask a question. I know we could talk forever, but we're only
I
going to
know.
talk
We'll
for a
have
few
to
more
do this
minutes.
again, but
I
I
know.
gotta
We told you
do.
hard stop at 8:15.
Yeah.
So, can you speak to products that you recommend or things that you recommend for your cancer patients who can't take hormones or who you don't recommend? Are there things that you turn to a lot? We have a lot of questions, people talking in, they're having cancer treatment and they have no libido, for example, or some of the other things that we're talking about. What kinds of products can they look to that are hormone free that can help with some of the symptoms that they may be experiencing?
So I think there's a whole supplement industry, right, that is out there, and then there are prescription medications. So vaginal estrogen, hot flash medications, there's a lot out there. There is Veoza, there are antidepressants, there are nerve medications. There's a whole thing for hot flashes. And the choice for hot flash medications really depends on what other symptoms that you're having. So if you have overactive bladder or you're waking up often in the night to urinate, then a drug like oxybutynin can help you with your hot flashes and overactive bladder. If you have neuropathy from chemo, gabapentin might be the choice. So you see, we start to kind of tweeze that. Veoza is a drug that is approved it's not hormonal, it's approved for hot flashes. It is a great drug. People really find that it helps, but it's expensive and the insurance often doesn't like to pay for it. So we sometimes have to try these other medications before we can go to Veoza. But there are supplements and there's a lot out there. And rather than giving you a laundry list because they work differently for different things, my thing on supplements is this. Even though they say non-hormonal, that means they just don't have estrogen, but they may have phytoestrogens that we don't want
Right.
in supplement form. Phytoestrogens in food, we love soy, flaxseed, all great, but in a supplement, it may be too much. So check always the ingredients with your doctor. What is the data behind the supplements? Is it a fad or is there really something that can help? But there are some products that people like. Bonafide tends to make some good products. Reverie for non-hormonal vaginal dryness. They make Relazin, which is a great hot flash medication. And there's some others as well, but it really depends on, again, individual things.
I want to give you one before we wrap this up. I know you have a book coming out, that you're working on a book called The Big
Beyond the
Pink.
Pink.
Sorry, I
Yeah.
was like I just made that up. Can you tell us when it's coming out? What a little bit about the book?
Yeah, absolutely. So literally it's everything we talked about today. Like this is the book it's called Beyond the Pink. It is a patient-centered guide for all of the mental and physical challenges after breast cancer and during breast cancer. And for people who are previvors, who are at risk but have not had breast cancer, people living with metastatic disease. And it's everything that we talked about. It has some stuff on menopause, but it's talking about sexual health and bone health and brain health and heart health and mood and your body image and ways that you can thrive. It's really written on how do you live your best life with or after a cancer diagnosis? And everything that I talk about, it's in this book. And so I'm super excited for it. It's coming out next September, but hopefully midway through early 2026 we'll have pre-orders. But I put everything in that book, so I'm thrilled for it. And even though it's mostly done, every day I'm like, oh, I got to add something else. And my editor is like, you can't add anything else. Okay, you're way over your page count. But I keep wanting to put more helpful things in the book.
Well, then you're just gonna have to write a second one, I guess.
Yeah, we'll go with it.
I see
Well,
all the hearts coming as you're talking, so there's lots
people
of
love
love
you.
being sent to
Oh,
you because I can see it. Like,
I can't see it, so I'll take your word for it.
they're
A lot
all
of
like
hearts.
coming up, so it's a lot of hearts. So
Awesome.
A
It's
lot of
great.
hearts.
A lot of
Yeah.
hearts.
People are just, we have one that says thank you for being authentic in your reach for all of us. So people
Yeah.
are very grateful to you. We are very grateful to you. I know you have a lot going on, so we're going to let you go.
Yep.
Thank you.
Thank you so much.
Thank you for
And
having me, and we'll do it again. And we'll see
can't wait to
everyone
see you in January.
in January.
January 11th, 2026. She was amazing last year. Star this year as well.
It's gonna be great. We'll talk soon.
Thank
Bye.
you. Bye.
Bye.
Bye.